Welcome back to Medical Monday. We're so glad you're with us. I'm here with Dr. Jack Erter from Tennessee Oncology. We're talking about blood cancer. That means leukemia, lymphoma, myeloma. I'm starting to get all these words down.
You're doing great.
And those should ring a bell with a lot of you. I'm sure it does, just like me. You've known someone, or maybe you've had one of these diseases. And Dr. Erter's here to answer your questions tonight. You're a South Carolina guy.
Yep.
How did you get to Tennessee?
So I was born and raised in South Carolina near Columbia, middle of the state, and probably, I think, roughly 10th generation South Carolinian, which in South Carolina, that basically means you don't leave.
No.
You know, you're not allowed to. And oddly, my sister and I, out of all my cousins, everybody are the only two that left.
You're the black sheep of the family.
And we've never been forgiven. But I went to medical school in Charleston, South Carolina, at Medical University of South Carolina, which is one of the older medical schools in the U.S. And from there, came to Vanderbilt to do my internal medicine training, which is actually kind of where, during my intern year, that I kind of learned that I really like leukemia and taking care of these patients, and that sort of grew into my career, as it were. And I'd spent 3 years of fellowship at Ohio State in Columbus, Ohio, for hematology oncology, and that's one of the big chronic leukemia centers in the country, and a big transplant center, and then came back here to practice.
Something you said just struck me. You said, I learned I like taking care of patients who have leukemia. I think that would be so incredibly hard because not every story ends well.
Correct.
And as you have a personal relationship with these patients, what draws you to it then? Why?
And it's funny you say that. I mean, that's definitely one of the things that I realized pretty quickly, that the fact I like this is unique. A lot of people that I'm training with don't like this at all.
No.
And I think it was multiple things. I think part of it is I definitely enjoyed that aspect of being there sort of in the trenches with patients going through this sort of a diagnosis. I definitely enjoyed the science of it. I mean, which even then, you could see things rapidly changing and just new developments. I find that very exciting. You know, what, again, we kind of touched on this in the last segment, but what we do now is so different than what we did even 10 years ago. And in most disciplines, that's really not the case.
Yeah.
You know, your typical
broken arm's a broken arm.
Right. You know, and putting doing a colonoscopy is pretty much what it was 10 years ago, and that's not bad. It's just kind of is. I kind of like that. It's challenging trying to keep up with everything, and it's getting even more so now as all these different fields in cancer rapidly develop. And it's sort of a snowball type of effect now. There's so many new therapies that it can be challenging to keep up. But
well, I'm glad there are people like you that like that challenge, but also like taking on the challenge of meeting the patients in the trenches.
Yes,
Let's talk to Mary. She's on the line. Mary, thank you for being with us here on Medical Monday. What's your question?
Is there any new treatments out for non-Hodgkin's lymphoma, the follicular kind?
Hey, Mary, thank you for your question. Absolutely. So with non-Hodgkin lymphoma, and specifically follicular lymphoma, there are new drugs that have been approved in the past 24 months, including oral drugs, couple classes of pills that have been FDA approved. You know, in addition, the clinical trial options have become very, very good in blood cancers. And one of the reasons is that even though we have different names for these different blood cancers, the originating event is often quite similar between one and another. And so we're starting to learn to use a drug that might be FDA approved in multiple myeloma to treat non-Hodgkin lymphoma. And so, you know, I think that those are very good avenues to look into with your oncologist. And, you know, between the FDA approved parts and the trial options that are out there.
But how do you push your oncologist? How do you say, isn't there something more?
Right.
I mean, because that's such an open, you don't know, you don't know.
I would tell you that most oncologists, and this might be unique to oncology, but I have found this to be true, both not just for myself, but with most of the oncologists I work with, that they're pretty open to hearing what you know, well, here's what I think, doc, and here, you know, I want to go to this place, and they'll kind of tell you, that's a good idea, or here's why you don't need to do that. But they'll also generally tell you, I want to send you to this doc. You know, I want to send you to this. I mean, and I send folks to other non-Hodgkin lymphoma experts all the time. I mean, that's something we commonly do. It's not a sign of weakness or ignorance. It's you're really kind of all in this together, especially when you're dealing with cancer.
One question I have, you're told you have cancer, which is shocking enough. And then if it were me, I'd say, I don't care what it costs or where I have to go, where I have to travel. I want to live and I want to get the best treatment possible. Let's get this done. Let's knock it out.
Right.
Maybe that's in your own backyard. How do you know? What questions should you ask so that you're getting the best care? Because this is a business.
Right.
There is money exchanged here.
Yep.
But your life's at stake, so how do you know?
It's a great question, and I think, certainly, one thing that is nice here in Nashville is that you can kind of feel pretty secure that you're going to be getting up-to-date care. I mean, there are areas in the country, and really not that far away from here, where I have seen patients that got referred in, and I'm thinking, I'm not sure what that doc was doing, but that happens much less. But what I would say that for the typical person who might be watching this right now, who lives in or near this vicinity, certainly within our group, you're going to be getting standard of care, up to date. This is how this cancer is treated in January of 2016. You're going to have a lot of clinical trial options, which is always a good thing to have on the table or on the back burner, as it were. And I think that the days where you needed to jet off to New York or MD Anderson or a tertiary center like that is for the most part kind of done. I mean, that there's the playing field is very level in terms of the information that's out there, the access to newer drugs. These things have all really changed compared to just not that long ago. I think a lot of that's due to the internet. I think a lot of that's due to the digital communication, having that information out there. I mean, I can remember when I started medical school having a big, thick 2,000-page Harrison's Internal Medicine textbook.
Right.
And, the idea of that now seems very antiquated, and that really wasn't that long ago.
And so doctors are sharing more because
Absolutely.
It's easier to share more.
And it's essential. I mean, the other thing not that long ago is that you didn't have many options.
Yeah.
And now there's so many options, and they're so widely disseminated to all corners of the U.S. certainly, that it's it's very hard to get caught really getting substandard care. I think when you're in certainly a
Bigger
metro
city,
area,
sure.
right?
Yeah. Mary, hopefully we helped you there. We have Shirley on the line now. Shirley, good evening. Thanks for being with us. What's your question?
Yes, I had that. Excuse me, I had thyroid cancer, and they removed it. Would it be any left in my blood?
Well, Shirley, I'm sorry to hear about the diagnosis, but certainly as cancer diagnoses go, thyroid cancer is very treatable, generally just with surgery. It is quite rare for there to be thyroid cancer that's going to be remaining in the bloodstream. There are tests for that and things that are typically done after surgery to kind of monitor those types of things, but most likely with your high percentage of thyroid cancers, you're probably in the clear.
Well, Shirley, hopefully that makes you rest a little easier tonight. And I would imagine with those tests after surgery, is that a one and done sort of thing or something that she has to go back regularly and just get checked out?
Right. Usually that's something we follow along over the years. And there's a lot of details that go into exactly what you do after someone has a thyroid tumor removed. But it's very variable from person to person, but typically it's an ongoing process with your oncologist.
When it comes to survival rates of different blood cancers, can you give me a few of those?
So it's with blood cancers, it's so varied that it's a little bit tough to get into real hard numbers. But one that we see a lot still, and that is very common, most people have known folks with, would be Hodgkin lymphoma. Generally diagnosed in someone in their 20s. Occasionally we see older patients, but the big spike, and we think about is a college-age student, that type of thing. I mean, this is a blood cancer that 50 years ago, was pretty much universally fatal, and that by the 80s, chemo was really eradicating most of the disease, and by now, depending on exactly what the stage diagnosis is, you're looking at 80 to 90% cure rates, which is that's pretty tough to beat. That's So, you know, that's one where things are very much on the good end of the spectrum. I think that with other types of blood cancers, depending on exactly which ones you're talking about, you know, what we've learned is that a lot of how people are going to do, including their length of survival, chance of cure, these types of things, are really rooted not in the kind of old school diagnosis, meaning is this a chronic leukemia or is this a non-Hodgkin lymphoma, but really in the genetics. And that's something we've gotten much more attuned to and much better at identifying. Is what change in a person's DNA led them to develop this cancer, and being able to tell a lot about how they're going to do, what treatments they need based on that.
That's very interesting. I want to get to that right after the break. We got to take a quick break. I want to talk about that because I think a lot of people would say, if I can make sure that I'm doing the right things and keep doing the right things so I don't get cancer, that's what I want to do. All right. We are still taking your calls. Give us a call if you have a question about blood cancer. If you'd like to talk to Dr. Erter, go ahead and give us a call. We're going to take a quick break. We'll be right back.